one of the purposes of this smaller type workshop meeting is to have really good discussion. At last year's and the year prior, we've had very good discussions. That's been some of the best part of the meeting. So we really hope that you will all engage with the speakers and have some good discussions.
Yeah. My name is Arshal Taf from WHO Injection Safety Program. Excellent presentations by everybody. I have two questions. One, a smaller one to Dr. Ward because he just presented. If he could kindly clarify when he mentioned 50% Hep C positive women in a small rural town. Just want to understand that. And the other question is towards Dr. Hellard when she mentioned community-based treatment programs. If she could elaborate, does that mean similar to the DOTS program, like avoiding travel expense and to the positive person? Just for my understanding. Thank you.
Yes, that's went to Hazard, Kentucky, in eastern Kentucky, which is the counties that have the highest rates of HCV in the state, and met with the health department there, and they were saying that in their county health department perinatal clinic, 50% of the women were hepatitis C positive. Now maybe they are seeing the highest risk women because they don't have access to other perinatal care and that type of issue, but it does I think reveal some of the prevalences that I think we have been previously unaware of in the country.
Thank you for your question. So for me, when I talk about community-based treatment, we have a variety of models that we're looking at, and I'm a believer in there's no one absolute model. So in the TAP study, that's that treatment as prevention study, it's a nurse-led model of care where we're actually treating people who are quite itinerant, and they're treated in a van. So the nurse has a van that's specifically set up where she's able to do blood tests, a fibrous scan, all of those things, and all follow-up. The clinic is a mobile van where we take it to drug hotspots. The particular people never see a doctor. The nurse does all the assessment, and then there is a paper check with the doctor. This is an experienced nurse, but so she doesn't do the prescribing, but it's a paper check. If we go through the paper check and we go, that person's fine because they've not got significant liver disease, treatment occurs through the van in the community. And if they've got significant liver disease, then that person's invited into the hospital. So that's one of the models that we're using. Another model that we're using is where we have what we call primary healthcare services, where they're healthcare services focused one-stop shops for people who inject drugs. At that service, you might pick up your needles and syringes and just head out the door. Or you might be there for your opiate substitution therapy, pick up needles and syringes. You might come in for a shower or a meal. You might come in for a wound care for your injecting. And at those services, again, you might see a nurse who does the assessment. They may or may not see somebody like me once, where I go, yep, and then treatment happens, and I may only see them on that one occasion or at the end just to make myself feel good to say that I cured them. But the management has been essentially managed by a nurse. There are some programs where, particularly some work being done by Greg Dorr and Jason Grebley and others in Sydney, where they're looking at directly observed therapy. But most of the work that we're doing, and I'm involved in those things, so it's been looked at, but most of the work that I do, it's not directly observed therapy. People in Australia get a 4-weekly script, and it's partly, so you basically get the 4 weeks, go away, take the treatment, come back and get your other script from the chemist. So it's we're not doing directly observed therapy. My experience has been that you don't need to. I may be proved wrong on that, but that certainly has been my experience. What I do and what I've done over the years is ask people what they would like. And our research has suggested, our qualitative work has suggested that some people would like to have their medication when they're picking up their OST and other people don't. And so we just give the person a choice. We ask them what they would like to do. I figure that they're the best judge of how they'll take treatment well.
Hi, this is Andrew Rayon from Replicor. Just a comment. Eradication of hepatitis B cannot be considered without considering hepatitis delta. And this is something where we'd really like to see the WHO do some work on this. We have a real challenge. France and Germany are the only countries which are leading the way in understanding how underdiagnosed this infection is. These patients progress to cirrhosis and death faster than HCV/HIV co-infection. The CDC just presented work a few weeks ago at the HCN conference at the AASLD, where this is now becoming a significant problem in the United States, with some centers reporting rates of their difficult to treat patients. Hepatitis B patients, 60% of them are Delta positive. And we have no approved tests. We have no good standardization of how to treat those, how to diagnose those patients. So we don't even know how bad the problem is. So it would just be a comment that I would think we should make Delta virus a very important component of eliminating hepatitis B, even though we're not really discussing it yet in the forum here today.
Hi there, Andrew Hill from Liverpool University. So it's a question to John Ward again for the US. So these states that have the restrictions on treatment access by disease stage or alcohol or drug use, do you think they're doing that to contain their drug budgets, given the price of the drugs? And do you think if the price of the drugs was significantly lower, that some of these states would lift some of these restrictions? Or do you think they actually believe that they're valid restrictions?
I think they are doing it for budgetary management purposes. They were the hepatitis C drugs were the first big blockbuster drug to come out after a big revision in Medicaid, which required the Medicaid programs to set their budget 2 years in advance. So when this was a real budget buster for them. So it was really, all the restrictions were all about controlling costs for their budgets. And so but I think some of those budget decisions, I have to say, it was really based on, also reveals some societal perceptions about what they think about people with hepatitis C, because I don't think they were cutting, breast cancer, therapy budgets, et cetera. So I think there's a little bit of a societal evaluation going on in there. The drug costs have declined. So they're down to less than $40,000, and as Angela said, I mean, our models for the U.S. show that it's really in cost-saving territory now. But now you really have to get over this really price stigma for HCV treatment. People have this hangover effect about how costly these drugs were when they came out for licensure. It was in the media a lot, and so there's a real hangover effect to show people that. As the drugs have dropped in just really 2 years, there's it's really cost saving on the societal level. So that's what they were. That's been that's what the state. It was really all about budgets. And so there's been some lessening about that. When you talk to Medicaid programs, they feel like not as many people came toward treatment as they thought. They saw the 3.5 million. They thought they were all diagnosed. They thought they were all in care. They thought they were all going to get treated in 1 year. And and so they really bought into that. And so they really clamped down. And now they realize that that burden wasn't as large. I think what would be the great leap forward, frankly, if those Medicaid programs actually had a thoughtful program for hepatitis C, for testing, and then some way of evaluating and to really budget out for hepatitis C, carve out a program. So that's what we'd like to begin to work with state Medicaid programs to do in the future.
John, can I push you on that a little bit? Because I guess I'm for sure price is a huge driver, but when you look at what the restrictions are, some of them maybe make some sense to do with fibrosis, maybe, but the ones that have to do with drug and alcohol abstinence really have no evidence base at all. And I guess, especially given the political changes in your country recently, do you really think that even if the drugs were very cheap, that many of the countries ideologically would allow people to be treated if they are not abstinent from injection drug use? I'm skeptical.
Okay. Hope you're wrong.
I hope I am too.
Well, I think they threw the kitchen sink at restrictions early on, and the sobriety ones came out of clinical trials in some part, and then about on the alcohol side, and then on the reinfection on the active drug user side. Like, why are we wasting these drugs? They're just going to get infected anyway. So again, we've been doing a lot of education about reinfection rates for people who inject drugs. I think we have to develop a really strong public health rationale for testing and treating injection drug users in the United States. I mean, I feel like we have one, but we have to start developing it as a package and really selling it to health systems around the country. I think we can get people to come around. I really do. I think it's an evolutionary process. I think we've made some headway in 2 years, not as much as we would like. Certainly not the shining example that Australia provides, but we'll have to continue to see how we can move forward on this. I do want to say also this opioid abuse epidemic, of which HCV is one consequence, is obviously a huge national problem, and it's a problem across political spectrum. So I think that also creates a much more positive environment and get something done. It's not a polarizing political issue. It's very much a cross-cutting issue now, and so I think we can get some good work done.
I hope you're right.
Yes, I'm Clemens Richter, infectious disease doctor from the Netherlands, but having worked in Africa for many years. I have a question for Dr. Hirnschau. You were quite pessimistic when you were saying it's very difficult to get any funding, and for example, from global funds for hepatitis care in low-income countries. So, and I wonder if that is could not be changed, because it doesn't make much sense when, let's say, HIV co-infected patients with hepatitis C are dying of liver cirrhosis or hepatocellular carcinoma, and they are taken care of opportunistic infections by the program. So it's just a difference now, opportunistic infection and co-infection. And so I believe isn't there a role maybe also for WHO, or what would you advise for countries to do? So when they apply for funding for the HIV program for the next years, could they not just demand, please, we don't need money only for HIV, but also for hepatitis C?
Well, I couldn't agree with you more, 150% actually. There was an opening for this discussion at the Global Fund board meeting a little bit more than a year ago, and we have worked very closely with the Global Fund Secretariat to make a very, very strong case to say exactly what you are saying. In essence, keeping people alive from one disease, and we know they are going to be very sick and dying from another disease, it doesn't make sense at all, and it's not from a human perspective, from an economic perspective, etc. So there is a little opening in the Global Fund rules. Countries can build into their concept notes, their grant proposals basically, they can build in some funding for co-infected individuals. And some countries have already done that, Ukraine for example, but they need to be, it really needs to be confined to co-infected people. And we were trying, WHO, we were, I think, strong advocates for pushing that window even wider open to say, it's about hepatitis C in general. But the donors who support the Global Fund at that point did not want to make that that commitment. There are a couple of other organizations that are now taking on hepatitis. UNITAID being one of them. We got just now an enabling grant. There is DNDi. There is also CDC, obviously. John is a very modest person. He doesn't maybe not have all the money that some of his colleagues in HIV have, but I really would like to acknowledge CDC as being an incredibly strong force. They're also supporting us financially in WHO, and we don't have many donors, and we value that collaboration very strongly. So I think we need to keep pushing for that, and I didn't want to come across as negative about it, and we have been doing that, but I think we need to put into the narrative or into the rhetoric with countries, don't wait for the manna to fall from heaven. You have to build this into your national programs, into your health financing plans, etc., because if you don't, and if you just wait, you're losing time. And we need to make a strong investment case that actually shows, by making these investments and by front-loading some of these investments, you're actually saving on the long run. And that's what we're trying to say. On the WHO guidelines that speak to hepatitis C, maybe we have not been strong enough in saying that there's a benefit for everybody, regardless of disease or state of disease progression, to start immediately. We were in the first round of the hepatitis C guidelines, obviously they're saying, well, if you have to ration, start with F3s and F4s, etc., etc. But in the next version, I think we will be much stronger about saying everybody should start as quickly as possible, as we are now saying also for HIV, and also emphasize the prevention benefit much more strongly by saying that. So stay with us. On Delta, clearly you have a point. I think we need to put more emphasis on Delta. In general, there has been insufficient attention to that, and also I think the means are relatively limited, but we will certainly want to do that also over the next year. So that's one of our things that we want to move forward.
It's just those patients don't respond to nukes, so it's useful to know if you have a co-infected patient.
Right.
You give them nukes or try to give them vaccines and they won't respond.
Yeah.
Can I add something? What about the pre-qualification of cheaper diagnostics and cheaper drugs? Because that would make the cheaper drugs more available for low-income countries.
So just to make sure everybody in the room knows, pre-qualification is a process where a company, diagnostics producer or medicines producer, applies to WHO to go through a process where WHO would certify sufficient quality of generic drugs. That means a company has to apply. Yeah. WHO cannot go out and say, oh, we want to pre-qualify you because we want to know how well you're doing. So we very much encourage that. We also encourage countries who buy drugs, who purchase drugs, to ideally look for quality assured drugs that could be WHO pre-qualified or through some other mechanisms, the FDA approved drug, etc. But we can only pre-qualify for those who are...
Yeah, but companies do apply, but it's a very, very slow process.
No, it's not at all. I think that is the myth that exists. I can show you, we have been, and it was true a couple of years ago, but clearly we have been lining up the docs. It's not my department, it's another department. We work very closely with EMP, and I think there's no more backlog. I think it's a bit of a myth from the past, and I can show you the details.
Peter?
Just a couple of questions. One to Margaret. I was just wondering how you feel case finding and testing is going to keep up with the high treatment rate, and whether the ones that have been going on so far, whether there have been ones already on the books, and where you think the bottleneck may be, and whether the new case finding interventions you're talking about, whether they're scaling up as quickly as treatment is. And then just one for John about, it just seems very similar, the lack of NSP map and the lack of sort of treatment or treatment only for F4 and things like that. Do you really think we'll ever get to a point where there'll be treatment for injectors in those states and NSP? Because they've been trying to get NSP in those places for a long time, and it looks like it'll never happen. I mean, do you think it will ever happen?
You mean SSPs?
Yeah, sorry, needle and syringe provision. Yeah.
Okay, I'll go with Margaret first.
So yeah, I think, Peter, the first lot of people who are being treated are predominantly people who have been in tertiary hospital health services, and so in some ways the sort of treating the people we need to stop the deaths, I think we'll get that done in a couple of years, because we're treating a high number of people like that. And I think you're right, the challenge will be, how do we make sure we treat 5,000 to 6,000 people every year? And the modelling, I didn't go into all of the details for want of time, but the new modelling that we've got is saying that will be a real challenge, that to ensure that we keep on treating people who inject drugs. So to stop the deaths, we'll be able to reach those targets, we think, pretty quickly. But to stop the ongoing transmission, to keep that number up, will require community-based, as I said, so there were sort of a series of things. We think, looking at the models, community-based is important, but not as important as we might have thought, but in terms of numbers and capacity, community-based. And then not losing somebody from the cascade. So that would be a rapid point of care test, regular, so on-site antibody, RNA, FibroScan, a pre, all of that happening at that kind of one moment to not lose somebody from the cascade, because that's our biggest risk, is to lose people out of the cascade, and it's very easy for that to happen very quickly. So I think it will be our challenge, and I think that we will need, and that's a lot of the work that we're doing at the moment, is going, how do we ensure we don't lose people from the cascade, and what do we need to do to have that not happen? That if somebody walks into a needle and syringe program or is having OST, how do we make it that they, in a way, are the low-hanging fruit and they get captured, tested, treated as quickly as possible? So I think we'll be able to tell people how we went, I reckon, in about 3 years' time, because I think that's when the rubber will really hit the road as to whether or not we're still being able to maintain treatment numbers and treating the right people. Yeah, but it will be, for me, an interesting challenge, but hey, bit of fun.
As far as syringe service programs, things have gotten better. For the first time, the federal government could begin to provide money to syringe service programs for everything except buying the syringe. So shows you where we are. Some states have really done a complete about face about syringe service programs. Kentucky being an excellent case in point, and they changed their law to permit syringe service programs, and within 1 year they've developed 15, around their state. It's a fairly conservative state, so it takes leadership and takes education of the public about what's valuable and what can this provide, and so that is happening. I think that change in federal funding language is allowing CDC to be much more of a promoter of syringe service programs. We've been sort of muzzled because of the political environment, frankly, as a government agency. So that's changing. So I really want to, I think over the next few years, I would really like to bring syringe service programs sort of out in the cold and bring it in as really just a routine preventive service like vaccinations is and everything else that we do at CDC. I think that's the opportunity we have in front of us. As far as treatment, I think we can get there in treatment. As I mentioned earlier, I think we need to get, I don't think we've done enough innovation. I don't think we've done enough partnership development to bring together Medicaid, community organizations, experts in injection drug use prevention and care, and pharmaceutical companies, frankly, and say, okay, what can we do about this problem together? Because this is really a public health issue. These people you're not treating them for their liver disease. You're treating them because they are a risk to others. So it's really a public health intervention. How can we come together and really develop an innovative approach that takes into consideration drug cost and what you're preventing by treating someone, what else you have to have in place, syringe service programs, drug treatment, to really have a comprehensive program. So, please.
I have a question for all of you, because you represent here very successful national programs, or at least in comparison with other countries. Can you foresee a reduction of available patients for treatment because of inefficiencies in screening programs? It's in the very beginning, countries without limitation in the access can treat easily. What's going to happen 3 or 4 years later? Do you have an estimation in your successful countries?
We have this situation in Egypt right now, where we have treated most of the people who know they are infected, have been treated already, and all our treatment centers I mentioned in my presentation are now almost empty from patients. So we are starting a very big screening program, and we are wondering if this should be done voluntarily or compulsory screening. And we have decided to screen inmates of prisons and anybody who is admitted inside a government hospital, and students, university students, and pre-marriage certificate, pre-marriage and pre-licensing. But the main issue is, do we do it compulsory or is it voluntary? We don't have an answer yet.
Stay voluntary.
Sorry?
Stay voluntary.
Because the thing is that very few people will come and on their own to...
It's only obligatory for the military recruitment, so that one has to be obligatory.
Can I follow up on that? One thing I had heard early on in the program was that there was problems with confirming SVR12, that people weren't getting their SVR. And I was wondering what's happened with that.
Well, about half of patients didn't come back after 12 weeks to see if they really have achieved SVR 12 or not. We have done something which we think might help, which is issue a certificate, which will show that this particular patient is cured of hepatitis C. And we hope that with this certificate, he will have the stigma surrounding HCV removed. And this way, we can encourage people to come back. But we are trying to get them back, and it doesn't happen to all patients, you see.
Sorry.
I have a question for you now. Do we still need SVR12? If we consider scaling up at large scale, national programs, we need to simplify the diagnosis algorithm and the monitoring. So do we still need SVR12?
That was something I was going to talk about tomorrow, but it is a good question about whether if the efficacy of treatment is so high, can we just assume that everyone that's treated is cured? I don't think we're quite there yet, because I think we are seeing still with the treatments, we are seeing definitely groups that don't achieve the high rates of cure, and I think you give people a false sense of security if they think they've been cured and they haven't been cured. But I think it's possible that we could get to there. I think I would probably personally prefer a strategy where you have a very simple way, people potentially having, for example, a dried blood spot test that they do themselves and confirm their cure. They don't necessarily need to go back to a healthcare facility. But I think not confirming cure in high-risk populations, you're going to continue to have transmission ongoing. People will get reinfected anyway, so you may want to still be testing them to confirm they were cured the first time. But it's an interesting argument, discussion. I think we are just about out of time. If maybe Gottfried wants the last word.
Well, it's not about the last word. I just want to say we talk about the whole issue of harm reduction. And I think the emphasis really needs to be that we need to have a comprehensive package. And we cannot just single out one intervention or the other and focus on one or the other. And I think we need to make the strong point that hepatitis testing and treatment needs to become a standard element of a harm reduction package, and I think that's what we really need to push for. On the SVR12, I agree. I don't think we are there yet, and I think we need to look into this more carefully.
Okay, so thank you to all of the speakers and to the audience for the questions. I think this was a great first session to the meeting.